disease theme today. I'm going to be talking about malaria and other tropical diseases. So the objectives of this presentation, I'm going to describe various bacterial, viral, parasitic, and protozoan infections commonly associated with tropical diseases. I'm going to outline clinical presentation, treatment options of these disease states, and we're going to focus in on presentation, diagnosis, and treatment of malaria. So I've kind of broken this up into sections, so bacterial infections starting with those, viral infections, and then parasitic and protozoan infections. Now, granted, these aren't going to be things that we're going to see all the time, but like Dr. Hagen was mentioning, more and more people are traveling to these countries where these diseases are endemic, so it's a good thing to be aware of these types of disease states. So starting with your bacterial infections, there's basic traveler's diarrhea. So this is spread by contaminated food or water. Most likely bacterial in nature, and the organism that we typically see is E. coli. However, you can see other organisms such as Campylobacter, Shigella, Salmonella, and even protozoans such as Giardia, Entamoeba, and Cryptosporidium. So prevention strategies are big here. So essentially, making sure you're not getting these contaminated food and water in your system. Treatments, if patients are losing a lot of fluids to diarrhea, you want to make sure they're adequately hydrated. You can use Imodium, loperamide as needed, and Pepto-Bismol as needed as well. For antibiotics, maybe indicated for treatment, prophylactic antibiotics are not routinely recommended. You want to think about like a risk-benefit ratio here. The types of antibiotics used, typically fluoroquinolones, azithromycin, or even rifaximin can be used.
I have something there.
Mm-hmm. Sure.
So, just following the staff so that everybody can kind of get perspective. I am ultra aggressive with giving a patient that's a traveler antibiotics to take with them when they go because of my experience with traveler's diarrhea. Meaning that I will give you Cipro, whatever to take with you if you're going to this area. Sometimes I'll even recommend you go ahead and take it. You're going to be there for say it's a business person that's going to be there for 5 days.
Mm-hmm.
And this is very important. Or say it's somebody going to climb Mount Everest and they've spent $50,000
just for the permit.
And they've got to get out of the camp, you know what I'm saying, to get to the mountain. I'm just curious what everybody else, we put you on the spot.
I give it all the time, so I educate. I don't have them take it already, but I have them keep it with them in case they need it in the first sign of symptoms. I talk to them about the difference, and if they want to wait and try to hydrate, take loperamide, but most of the time when someone's traveling to a place that's, you don't know the food sources, they're going to Mexico, wherever, I'll give them Cipro, 500 BID, and have them start taking it first time.
Absolutely. It's always a big Cipro or Cipromax. I tend to use Cipro.
Mm-hmm.
Sometimes I give them both, one for respiratory, depending on where they're going. I do make a difference. I say, 2 or 3 loose form stools a day, no fever, no blood, no significant cramping. It's just from traveling, just different strengths, not a true infection. Versus, 5 or more stools, abdominal pain, blood in your stools, fever, right?
Chris, I do the exact same thing, because a lot of people have travel anxiety diarrhea, as they travel, and it's a very big thing. I think a lot of people experience that, right? You don't have to raise your hand. But except Alan raised his hand. So I do the same thing, fever, cramping, really kind of explosive diarrhea that's kind of ruining your day, so to speak.
Or if you're going to talk about
as someone who has experienced in a couple of different countries, I definitely give them something to have on hand, just like you're saying.
All right, and then we have cholera. So can be seen in Africa, parts of Southeast Asia, Haiti. Also caused by bacterial infection with Vibrio cholera and contaminated water or food. Symptoms you may see here, again, you get that watery diarrhea, vomiting, but you can see more serious symptoms here, such as circulatory collapse, renal failure, and even shock. So again, prevention strategies are important here. For treatment, you want to make sure they're adequately hydrated again, and then antibiotics may be indicated, such as doxycycline, azithromycin, or ciprofloxacin. Diagnosis can be made by stool culture.
But not our standard stool culture. The Campylobacter, Shigella, and Salmonella is the only thing that we run routinely on our stool cultures here. So I don't know how we have to look at it differently.
So take a travel history and know
Mm-hmm.
if that's not original.
At Presbyterian, I think when I was on Pete's, they like had a little prompt box when I was in stool culture that says, "Do you want to add Vibrio?" And I asked like,
That's a good question. I have to look on the order
Yeah.
to see if that button's there.
I don't think it's there outpatient.
It may not be.
Typhoid fever. Another bacteria here, Salmonella typhi, seen in parts of Southeast Asia, Africa, Caribbean, Central and South America. This is by water or food contaminated by feces. Patients may present with symptoms such as fatigue, malaise, fever, anorexia. You may see hepatosplenomegaly, a macular rash, or intestinal hemorrhage. Treatment here, some of the same antibiotics, so your fluoroquinolones, azithromycin, and Herceptin may be an option here as well. Of note, there are vaccines for typhoid fever. There's a couple different options. So we have our capsules, the Votiv. This is taken 1 week prior to travel. This is a live vaccine. And then we do have an intramuscular injection, the Typhon V, taken 2 weeks prior to travel. This is an inactivated vaccine. Leprosy, also referred to as Hansen's disease. This is caused by Mycobacterium, specifically Mycobacterium leprae. So there's around like 2 to 3 million people estimated worldwide to be disabled by leprosy. The greatest incidence is actually in India and Brazil. Now, interestingly, there's a couple different ways that this can present. We can't think of it as like skin lesions, more kind of like a derm in nature. So with nodules, plaques, thickened dermis. So actually, skin biopsy is needed for a definitive diagnosis. However, patients can get other complications from this, including nerve damage, which that's where you get like the significant disability from. It can be spread person to person by coughs and secretions. And then interestingly, some armadillos in the U.S. are actually carriers of Hansen's disease. Treatment duration is extended here, can be up to 2 years, from 6 months to 2 years, typically with either dapsone, rifampicin, or clofazimine.
We kick them out of the city, we shun them. Right?
Wrap them in toilet paper.
Let's make sure things haven't changed in the last 2,000 years.
So yeah, not one of your common ones there, but can be seen. Varroa ulcer. This can be seen in parts of West Africa and Australia. Again, we see that Mycobacterium infection here. This is Mycobacterium ulcerans. It's not really known exactly how this disease is transmitted, but the thought is that it may be spread from insects found in water. You can see patients presenting with swelling of the skin, papules, nodules, plaques, ulceration, even bone infection, and disability. Diagnosis is by doing that acid-fast bacilli smear, so similar to like the TB diagnosis. You can also do culture and PCR methods here. Treatment with antibiotics, rifampicin, streptomycin, clarithromycin, and moxifloxacin. And then of the bacterial infections, I didn't include Mycobacterium tuberculosis in here because that's kind of like its whole other topic, maybe for another day. So moving on to viral infections. Hepatitis A, which I'm sure you're all familiar with. So hepatitis A virus transmitted by ingestion of fecal matter. So this is more commonly seen in the areas with kind of limited access to clean water and really kind of inadequate sanitation. So parts of Africa, parts of Asia. Patients may be asymptomatic, or they may have these symptoms of fever, malaise, jaundice, nausea, and abdominal discomfort. Treatment involves rest, hydration, and we do have vaccination as well, obviously. It's a 2-dose series. There's the Habrix, the Vapta, and then the Twinrix, which is a combination with Hep B. It's a 3-dose series. And there's immunoglobulin as well. With hepatitis B, so kind of similar. This one's spread by contaminated blood or body fluids. Again, you can see those kind of symptoms of malaise, jaundice, nausea, abdominal discomfort, liver disease as well. Again, seen in areas with not the greatest sanitation, or really areas that don't have really those preventative measures, so like personal protective equipment in kind of like field medical areas. Patients at high risk are having sexual encounters with new partners, traveling to receive medical care, volunteering to provide medical work in foreign countries. And then the vaccination for Hep B, 3-dose series, either the Enterix B, Recombavax, or that Twinrix combination. And then the immunoglobulin is available as well. So specific recommendations, CDC is a great source of information here. May be somewhat difficult to navigate, but all the information is there. Yellow fever. This can be seen in parts of South America and Africa. So this is caused by a virus, specifically in the genus Flavivirus, and the vector here is mosquitoes, so it's spread by mosquitoes. So prevention, obviously you're going to want to try to involve reducing that mosquito exposure. So there's strategies we can use here, having proper clothing, insect repellent as well. Patients may be asymptomatic, or they may have these flu-like symptoms, including chills, nausea, headache, vomiting. Treatment's really supportive, so giving fluids, analgesics, antipyretics. This is diagnosed by an antibody test, and we do have vaccine here as well, but this one's only available through the CDC designated centers.
So can we give that here at our clinic? Sarah?
No.
Cody?
Yes.
So yes, so Rev and I, Dr. Snyder and I, had to go through like a extensive course to basically get signed off to be able to carry the yellow fever. Before all you guys were here, we were putting this together. And you have to have a designated person who, quote unquote, oversees it. The CDC has to take this online course, do all these things. And so that's Dr. Snyder and I for our clinic. We have 2 of us just in case one of us.
We had a question yesterday if one of you has to be in the clinic
We do
for us
not.
to give it. Okay.
We do not. So before, for Lakeside, it's actually Dr. Cook.
Oh.
So that covers it.
I've been doing it for his license.
Yeah.
So you can do it on their, at any lakeside?
You can?
Yep. Or the resident.
Lakeside Family Medicine, not Lakeside Primary Care. So if you're talking about training on,
Yeah.
that's primary
Primary
care. So, and the other thing, Mark and I have both had this before, and it made me feel like crap. Yeah,
I know
just,
it before.
It's a live vaccine.
yeah. I didn't feel too hot for about 72 hours afterwards. Just so you know, when you're getting it.
And then interestingly, like, if you're traveling to certain countries, you actually have to have proof of vaccination to travel to those countries
You have
as
to
well.
have a special card that
Mhm.
certifies that you got it.
Yeah, we have to stamp this card. There's a process. Don't just give me yellow fever and then walk out the door. So nurses should take care of that.
You know, we have our own booklet on our site too
Right.
that we have to stamp into, saying it's a big deal for whatever reason.
Right now, we're not ordering it into residency clinic.
Yeah,
We have to borrow.
we have bars in there.
So, Japanese encephalitis, found in parts of Asia and Western Pacific, or in those type of rural agricultural areas. Again, we see that flavivirus spread by a mosquito vector. Patients may present with rigors, seizure, coma, and may actually die from this. Prevention, again, reducing that exposure to mosquitoes. There is a vaccination for this as well, ACRO. This is typically recommended if you're spending extended period of time, so greater than 1 month in endemic areas. This is a 2-dose series, spaced 28 days apart, with the last dose given 1 week prior to traveling. And treatment is really just treating the symptoms of the disease. Dengue fever, another flavivirus spread by mosquitoes. This can cause hemorrhagic fever and dengue shock syndrome. So there's several different symptoms you may see in patients. You can see sudden onset of fever, headache, mouth and nose bleeding, muscle and joint pains, vomiting, rash, diarrhea as part of that febrile phase. There's also hypotension that can be seen, pleural effusion, ascites, GI bleeds. And then going along with that, you can see seizures, altered level of consciousness, itching, and slow heart rate as well. Prevention, reducing exposure to mosquitoes. As you can see, a lot of these disease states are really preventative in nature. So just knowing the proper techniques. No vaccines or treatment currently available for dengue. It's diagnosed by serologic tests and molecular methods. And it is endemic in Asia, Pacific, Africa, Caribbean, and parts of the Americas. West Nile virus, another flavivirus. Patients are typically asymptomatic, or they may have febrile illness. And it can cause rare neurologic symptoms, such as seizure, coma, and paralysis. Treatment here, again, just supportive care for the patient.
So do we see Eugene West Nile virus here?
In the U.S. or in Carolina?
Either.
I know it's in the U.S. I don't know if it's here.
Alan, what do you think? You see this in North Carolina?
Probably.
We do see cases of West Nile virus here. So almost every year we will have cases that go into the Presbyterian Maine or into CMC. They have to communicate with each other once it happens. They tend to be one-offs where people travel in most of the time, where they come into the area. But there, last year, the case that went into CMC, there's a lot of talk. I don't know how much you guys have seen it, Eric, you've seen it there, but there are talks about, as things get warmer, the mosquitoes continue to travel further up the coast, that we're going to have to keep these things on our radar more, because we don't figure it out by catching a bunch of mosquitoes. We figure it out as these viruses start becoming more endemic in an area.
Someone gets encephalitis.
Yeah.
Us with the cold and cough, we may never know we have it, or we have some weird viral illness, but somewhere along the line, someone's going to get a West Nile encephalitis, and they'll diagnose it through, someone who's really, really sick. About 12, 13 years ago, I was in residency, 14 years ago. It was, there were local cases. It was all the talk. I mean, hospitals really worried about it.
In Georgia, at Fort Benning, we used to have it much warmer. It's about 10 degrees warmer than here, and we used to see it all the time. We had to, or at least had to keep it on our differential for anything that was unexplained headache. If you have a headache that you can't figure out, someone's starting to show any kind of neurological symptoms, Rocky Mountain spotted fever and West Nile are two of the big things you got to keep on your differential. And the other thing is you guys should be impressed by the freaking Flavor Flav virus up there.
Yeah.
I mean, these are deadly things that these bad boys are.
That's the most dangerous animal, deadliest animal on the face of this earth. Mosquitoes. Yeah, they kill mosquitoes for more human deaths. Like almost all other animals combined. It's crazy.
It's neck and neck with the T-Rex. Can't confirm the T-Rex kills.
So
Let these witnesses
Got to put Zika virus in there too, another flavivirus. Again, mosquitoes. So with the Zika virus, this can be transmitted during pregnancy, through sex, blood transfusions, or through lab exposures. Most people are going to be asymptomatic or have kind of mild symptoms: fever, rash, joint pain, conjunctivitis. Typically do blood or urine testing to diagnose, and there's no treatment currently available. However, there is a vaccine currently in development. And then, interestingly, infants born to mothers infected with Zika can have serious complications, such as neurologic abnormalities and even Guillain-Barré syndrome. Rift Valley fever. This is actually not a flavivirus, so this is a different one. This is a flavivirus. This can be seen in kind of your more rural areas, so in Africa, parts with sheep and cattle, again spread through mosquito vectors. So patients may have fever, liver abnormalities, and rarely ocular disease, encephalitis, and hemorrhagic fever. Diagnosis here by molecular methods and culture, and treatment is supportive care.
I've actually never heard of that. I'll freely admit. So you just taught me something. So cattle in Africa and mosquitoes. All right.
And then one thing to keep in mind is that with these patients that have these hemorrhagic fever type symptoms, it's important not to give them NSAIDs or aspirin because that's going to increase their rate of bleeding. Ebola hemorrhagic fever. So the Ebola virus can be spread by contact with bushmeat, infected bats, or bodily fluids of infected persons. Patients may present with fever, headache, muscle pain, weakness, diarrhea, abdominal pain, hemorrhage. So you can see a lot of similar symptoms with these viral illnesses. Found in several different African countries. And the virus is usually detected in the blood after onset of symptoms. Supportive care treatment, and then there are vaccine and treatments are currently under development. So moving on to our parasitic infections. Schistosomiasis. So this is caused by parasitic worms living in freshwater snails. So you may see if a patient's like walking through freshwater barefoot and may become infected with schistosomiasis. There's 3 different species which infect humans, so Schistosoma masoni, Hematobium, and Japonicum. Again, you see contaminated fresh water is kind of the source of infection here. Patients may have rash, itching, fever, chills, cough, muscle aches. And patients can actually become chronically infected as well. Different types of symptoms here, so abdominal pain, you can see enlargement of the liver, blood in the stool, urine, and then it may actually increase your risk of bladder cancer as well. CNS infection can occur here too. So patients may present with seizures, paralysis, spinal cord inflammation. Diagnosis, you can actually look for a microscopic examination of the stool or urine for the actual parasite eggs themselves. 85% of the cases are in Africa. For treatments, really kind of preventative measures, making sure you're not walking barefoot through fresh water in these endemic areas. So there is a drug called praziquantel, brand name Biltricide. This is a PO medication, just a one-day treatment option, 40 to 60 mg per kilogram in 2 to 3 divided doses. How this drug actually works is kind of neat. So you can see this picture right here. These are kind of like the suckers here. So that's what the schistosoma actually uses to latch on to the blood vessel walls. So how biltricide works is it actually increases the cell permeability to calcium in schistosoma species, and that causes contractions and paralysis of worm musculature, which leads to the worm detaching from the blood vessel walls and kind of being dislodged. So there's no vaccine available. Again, just preventative measures here.
Sorry for that one. Was that the one where you pee in fresh water and then it crawled up? Jeez.
What movie were you watching? Again?
Stand by Me?
I know what he's
Yeah,
talking
I've heard
about.
that. I've heard that before.
Yeah.
I'd have to see if that's
I
the
don't think
same.
No, I think it's
Something
something
like
like
this.
I know what you're talking about, but
Yeah.
I'll look into that.
She go for peeing in the water.
Pee in the water.
Pee in the bushes.
I don't think you even have to pee, it just crawls up your urethra.
Yeah.
Yeah.
I thought
You
it
would
was
probably
all over.
Kind of swimming or
No,
something.
it's just a bladder cancer thing. It's
Yeah.
So guinea worm disease, or called trichunculiasis, seen in Africa, Asia, Middle East. So this is an infection caused by drinking tepid water containing water flies infected with the nematode Tricunculus mediensis. Patients may present with fever, rash, nausea, vomiting, diarrhea, dizziness, cellulitis, abscess, sepsis, joint infections, and tetanus. So interestingly here, there's no real treatment. You actually have to take the guinea worm out of the skin, so you have to take the whole worm out. And it actually kind of bores through a blister in the skin. Teniasis and cysticercosis. So this is another parasitic infection caused by tapeworm species. So our Tinea species, Tinea saginata, Solium, and Asiatica. Humans can become infected by consuming undercooked beef or pork. So you may want to stay away from those kind of like street vendor type deals.
Prevalent on vegetarian.
Yeah. So may present with symptoms of abdominal pain, appetite loss, weight loss. This is not a good option for if a patient wants to lose weight. You can actually find Tinea eggs in the stool, so that may help with your diagnosis. And then the one species, Tinea solium, can cause cysticercosis. So this is the more serious deal here. So this is where cysts form in the brain or spinal cord, causing seizures, headaches, brain swelling, stroke, and even death. This can be diagnosed by CMS imaging and serologic tests. And this is really found kind of worldwide. Treatment here, so we have our anti-helminth drugs, which works against these what we call helminths, these parasitic worm infections. So specifically, we have albendazole. This works by degeneration of microtubules in these helminth worms. It also depletes glycogen, glucose uptake, and ATP production, so the worm eventually dies. We already talked about praziquantel. Niclosamide is going to inhibit glucose and anaerobic metabolism in these helminth worms. And then specifically for that more serious manifestation of the disease, the cysticercosis, dexamethasone may be indicated, along with anticonvulsant therapy. Lymphatic filariasis. So that, again, we see these nematode, these worm species, specifically the Wucheria and Brevia species here. And these actually can be transmitted by mosquitoes. So this is kind of interesting how these patients present. You may see lymphedema, elephantiasis, so that massive swelling. You can see a hydrocele, so the swelling in the scrotum. And these patients may also get what they call tropical pulmonary eosinophilia syndrome. So this is an accumulation of eosinophils in the lungs. Can be characterized by coughing, asthmatic attacks, and an enlarged spleen. Diagnosed by microscopic examination of blood smear. And then treatment is available through the CDC, something called diethylcarbamazine. This inhibits arachidonic acid metabolism in nematodes, making them more susceptible to the actual innate immune system of the person infected. And then we have our various soil-transmitted helminth infections, more specifically with our Ascaris, Trichuris, Ankylostoma, and Nicator species. It's found in a lot of, just generic tropical climates, so warm or moist climates. This can be passed through the feces of infected persons by walking barefoot on soil. Treatment here, again, we see that albendazole or mebendazole, and this is just a 3-day treatment duration. This is diagnosed by stool sample. River blindness, or onchocerciasis. Again, we see this nematode species, Onchocerca. This can be spread through bites of black flies, found in tropical climates near streams or rivers, hence the name. Patients may present with a rash, nodules, and vision changes. Can be diagnosed by skin biopsy or PCR. Treatment here includes ivermectin, which works by increasing the permeability of cell membranes to chloride ions, which causes hyperpolarization of these nerve or muscle cells in the nematode, and plus or minus doxycycline here.
I'm going to take ivermectin and doxy with me next time I try it.
Things. I never want to have a baby, and I never want to try it. That's what I learned in the past 2 weeks.
I just stay here.
So finally, moving on to our protozoan infections, which includes malaria. We have Chagas disease, or trypanosomiasis. So this is caused by the parasite Trypanosoma cruzi. The infection here is acquired through contact with feces of an infected triatomine, which is the kissing bug, which I have a picture of on the next slide. This can be seen in rural areas of Central and South America, and it presents in a couple different ways. So you have an acute phase, where a patient may show fever, fatigue, headache, loss of appetite, rash, diarrhea, vomiting, body aches. And then there's that specific Romagne sign, which is kind of like that periorbital swelling associated with lymphadenopathy, maybe indicative of Chagas disease. Patients can also become infected by congenital means, also through organ donation, blood transfusions, through lab accidents, or contaminated food or drink. So a few ways of contamination here. There's also a more chronic phase where patients may show complications of cardiac or intestinal nature. And there's that kissing bug that we see, vector. And interestingly, patients may actually remain asymptomatic for life but be infected. Diagnosis is done by a blood smear, but this can only be done during the acute phase, not that chronic. You can also use antibody detection or molecular methods. There are medications available through the CDC, including ifurdamox and benzonidazole. So how these work is they actually generate radical metabolites that break down the DNA of trypanosoma. Leishmaniasis, found in tropics, subtropics, and southern parts of southern Europe. This is transmitted by the bite of sandflies, carrying the protozoan Leishmania species. So you may think of this in a couple different ways. There can be a cutaneous disease causing skin sores, and there can be visceral disease as well, causing fever, weight loss, enlargement of the spleen and liver, anemia, leukopenia, and thrombocytopenia. Diagnosis here is done by tissue or bone marrow. Can be examined under the microscope, or you can do looking for antibodies, serologic tests.
So I'm not naked and afraid got that.
Oh yeah.
It's also on boards. I actually had a picture on my boards, and we had another cutaneous leishmaniasis.
Yeah, I would add the Middle East to that too.
Okay.
So leishmaniasis.
Nice.
From there. So.
I saw a bunch of that in Costa Rica, like, especially in kids. The lesions look like pepperoni, circular. I couldn't eat pizza for a long time after I got home.
Yeah, I should have put a picture of the lesions on there.
So I mean,
But you can
since
put
we're
a shirt on
selling
outside,
in New York,
It's fun.
but they travel from the Middle East.
Travel from the Middle East. Yeah, so we saw it a lot. And I agree, it's a very circular lesion most of the time, which is what we would see.
So there is a couple different options for treatment here. Again, there's a medication that's available only through the CDC called sodium stibogluconate. Interestingly, this can actually be treated with antifungals, including amphotericin B and azole antifungals. And then we do have a couple other options, including cefacine. Mechanism here is really kind of unknown. May interact with the phospholipids and steroids in the parasitic cell membrane. And then pentamidine as well. This works by interfering with the RNA, DNA, phospholipids, and protein synthesis. Trypanosomiasis is more commonly referred to as African sleeping sickness. So again, we see that Trypanosoma species here. This is Trypanosoma brucei. This is transmitted by the tsetse fly, so Glossina species. You may see patients present with fever, headache, muscle joint aches, enlarged lymph nodes, itching, and weight loss. You can diagnose by microscopic examination of blood or lymph, and examination of CSF fluid. So, trypanosomiasis can cause CNS infection, leading to neurologic issues and even death. Treatment here, we do have pentamidine, and then a few other options: Suramin, Melarsoprol, eflornithine, nifurtimox, but these are only available through CDC. And then finally getting to malaria. So what is malaria? This is a vector-borne infectious disease caused by protozoan parasites. A little bit about epidemiology. So it's widespread in these tropical, subtropical regions. Around 3.2 billion people are living in areas at risk for malaria in around 106 countries and territories. So the World Health Organization is estimating in 2015 that malaria caused 214 million clinical episodes with 438,000 deaths. Malaria was actually eliminated from the U.S. in the early 1950s. And I was kind of reading a little bit into the history of that. It's really pretty interesting. So after World War II, there was a program put forth by the CDC and various public health authorities, which was called the National Malaria Eradication Program. So essentially what this consisted of is they put DDT, the insecticide, all over counties where malaria was thought to be prevalent. So the figure that I read was 4.5 million house spray applications were made. So essentially they sprayed DDT everywhere. They also did other things such as trying to eliminate mosquito breeding sites. And then over a period of a few years, like after World War II up to 1949, this kind of slow eradication process took place until finally in 1949, the country was declared free of malaria as a serious health risk.
Now we just have a lot more cancer.
Yeah.
After spraying
A lot of inconvenience, man.
Yeah, so, along with that, DDT is like disastrous for the environment, which is why it was banned. And if you ever read the book Silent Spring by Rachel Carson, she kind of goes all into that.
Yeah.
Or something.
There's a difference between breastfeeding and bottle feeding. Look it up.
So there's a few different Plasmodium species that are pathogenic to humans. One of the most common is Plasmodium falciparum. So this can actually cause severe malaria because it multiplies rapidly in the blood. Can cause severe anemia. The infected parasites can actually clog small blood vessels, and when this occurs in the brain, you can get cerebral malaria as a complication that can be fatal. Plasmodium vivax, one of the more prevalent species. So P. vivax as well as P. boval have this kind of dormant liver stage called the hypnozoite that can activate and invade the blood, causing a relapse up to several months or years later after the infected mosquito bite. And then P. boval is kind of morphologically very similar to P. vivax. Plasmodium malariae, if untreated, this can cause a long-lasting chronic infection that can last up to a lifetime. In some chronically infected patients, malaria can cause severe complications such as nephrotic syndrome. And then P. knowlesii. So this has a 24-hour replication cycle, so it can really rapidly progress to from an uncomplicated to severe infection. And fatal cases have been reported with that species. So the vector here, again, we see it's mosquitoes, more specifically in the genus Anopheles. So there's around 430 different Anopheles species, and around 30 to 40 will actually transmit malaria. It's found worldwide except Antarctica. So this is kind of a busy slide, but I'll try to talk you through this a little bit. So going through the life cycle, CDC is a great source of information if you want to learn more about this kind of stuff. But just the basic life cycle I think is good to know. So there's kind of different phases or terms for which part of the life cycle it's in. So human infection, we can see up here starting with 1. It's initiated when these sporozoites, which is one of those terms for which part of the life cycle it's in, are injected with saliva during mosquito feeding when they're taking their blood meal. So these sporozoites are going to enter the circulatory system. Within 30 to 60 minutes, they're going to actually invade your liver cells. After going into your hepatocytes, the parasite actually undergoes an asexual replication. The term for this is schizogony. And then, like we mentioned, that kind of dormant stage with Plasmodium vivax and Plasmodium ovale. So some of these sporozoites don't immediately undergo that asexual replication, but can enter a dormant phase known as the hypnozoite, which can lead to relapse later. These hypnozoites can occur with that relapse up to months to years later. So after it's released from the infected liver cell, it actually invades the red blood cells, so the erythrocytes. And then interestingly here too, people with sickle cell disease are actually immune to this invasion due to the sickling of the red blood cells.
So you know that there are theories that that's how sickle cell
That's why it still exists.
Yes,
right.
Evolutionary advantage.
Yeah, so there's the adaptations, and now it causes other issues, but
Right.
that's the ongoing thinking right
So they recognize specific proteins on the surface of the red blood cell and actively invade the cell. After doing this, it's going to go into the trophic period, which is kind of its feeding and nutrition phase. And this is actually followed by an asexual replication. So during this kind of feeding phase, this trophic period, the parasite ingests the host cell cytoplasm, breaks down hemoglobin into amino acids. This is a really important part of the life cycle, which is kind of where a lot of drugs actually work. So this asexual replication typically consists of 3 to 5 rounds, depending on species. And this is followed by a budding process where the erythrocyte ruptures and releases the merozoites, which is another form. As an alternative to this asexual replication, some of these parasites will actually undergo a sexual cycle and then differentiate into gametocytes, so the male and female germ cells. These gametocytes don't actually cause any pathology, so it's the asexual form that's causing this pathogenesis, not this sexual form. So they don't cause pathology in the human host, but they can disappear from circulation if not taken up by a mosquito. So formation of these gametes is induced when the gametocytes are ingested by a mosquito itself. The actual male form of the gametes will seek out the female form, and then within 12 to 24 hours, the resulting zygote kind of develops into this motile invasive stage, which is going to transverse into the mid-epithelium of the mosquito itself. So after that, they do another asexual replication called sporogamy, which culminates in the production of several thousand of those sporozoites, which takes us back to the infection of humans. So this process generally takes 10 to 28 days, just depending on the species as well as the temperature of the environment. So pathology and clinical manifestations associated with malaria are typically due to asexual erythrocyte stage parasites, like I mentioned previously. How these patients present, typically there's an incubation period. So following that infective bite by the mosquito, there's a period of time that goes by before you see the first symptoms. This can last from 7 to 30 days, with shorter periods observed with falciparum and longer ones with malaria. So signs and symptoms that we see with our patients with uncomplicated infection, you can see a cold stage, so essentially a station of cold, shivering. There's also maybe a hot stage with fever, headaches, vomiting. May also see seizures in young children. And then you can see sweats and fatigue during like a sweating stage. However, most patients will commonly present with kind of a myriad of these symptoms. Physical findings, you can see elevated temp, perspiration, weakness, splenomegaly, jaundice, enlargement of the liver, increased respiratory rate. For severe disease, infections can be complicated by organ failure or abnormalities in blood or metabolism. So you can see, I mentioned previously, that cerebral malaria. So patients may present with abnormal behavior, impairment of consciousness, seizures, coma, and other neurologic abnormalities. Again, since it's actually lysine or red blood cells, you can see severe anemia and hemoglobinuria. Patients may have acute respiratory distress, abnormalities in coagulation, hypotension, acute kidney failure, metabolic acidosis, and hypoglycemia. For other manifestations, we can see neurologic deficits from the cerebral malaria, so things such as ataxia, speech difficulties, deafness, blindness. Recurrent infections may result in severe anemia. And then during pregnancy, particularly with the falciparum species, severe disease in the mother can actually lead to premature delivery or delivery of a low birth weight baby. On rare occasions, you can get splenic rupture, particularly with the Plasmodium vivax species. And then nephrotic syndrome can be seen from chronic or repeated infections with Plasmodium malariae. And then again, we can see that relapse with the Plasmodium vivax and oval species in particular. So there's several methods for diagnosis. You can do microscopy. So the parasites can actually be identified by examining microscopically patient's blood on a smear. And this is kind of the gold standard. We do have rapid diagnostic tests as well, specifically the Binax Now malaria test. So this is an in vitro immunochromatic rapid assay for the detection of Plasmodium antigens. There's molecular diagnosis via PCR. There's also serology using immunofluorescence and enzyme-linked immunosorbent assays, your ELISA tests. And then important to think about is drug-resistant testing as well.
So one of the things about the diagnosis is, this used to be the case, that you can correct me if it's not anymore, but you had to, if you're going to do the blood screen, you had to do it during an acute flare of fever. So when we had people that we were watching for, the episodic fevers of malaria, if they went into an afebrile state, it was not as sensitive as when they were in a febrile state of the malaria. Mark, I don't know if you remember that at all. But I don't know if that's still the case, but that's how we used to have to check it. We'd have to hospitalize and wait until they're febrile and draw the blood and smear.
Yeah, you're going to be more likely to see it on the microscopy this and that.
And that's called a thick smear.
Yeah.
It's not the standard kind of smear that you put on a slide to count white cells and things. It's a whole different preparation.
Is it predictable fever curve? I seem to remember for malaria there's like a 72 cycle fever curve because of the
I think that's also dependent on the type of species.
Yeah, because it's varies between 48 hours to
Yeah.
72 hours.
Yeah. So like if we go
Like because of the life cycle and how it lyses the red blood cells, I think that's what causes it.
like the Plasmodium dulcei has like that 24-hour replication cycle. Others are differing in their kind of life cycle, so may differ how they present with that fever curve. So moving on to treatments, this is going to really depend on the clinical status of the patient, whether you determine it to be severe or uncomplicated, and then also determine on the infecting species and the drug susceptibility of the infected parasite. Agents used here, there's several of them, so chloroquine, atovaquone, proguanil, artemether, lumefantrine, quinine and quinidine, doxycycline in combination with quinine, again, clindamycin combo with quinine, and artesunate.
Can you get quinine? Is it available?
Doesn't know where that starts with an M.
Maybe they let it do it for malaria.
Metflu.
Can't give it for leg cramps anymore.
Yeah. I'm interested for
It's
malaria.
worse.
It's actually
Oh no, by itself.
For leg cramps? That's why I don't.
I didn't think it was available.
I get in comic book.
I haven't used it.
So this is a document that the CDC has on their website, and this is kind of like a treatment algorithm. So again, it's going to be based off of whether you determine it to be severe malaria or uncomplicated. So with that severe malaria, you typically do intravenous quinidine plus tetracycline, doxycycline, or clindamycin. If it's unavailable, you can get artesunate, which is only available through the CDC. With this severe disease, you probably want to admit the patient to the intensive care unit for continuous cardiac monitoring if they're getting that IV quinidine. So with uncomplicated malaria, it's broken up into the different species. So with Plasmodium falciparum, which is our most common, it's based off of resistance patterns. So if the disease was acquired in the mefloquine resistant area, you can treat the patient with atovaquone, proguanil. If the patient was got disease in chloroquine resistant area or chloroquine sensitive area, you want to go with chloroquine. And then the other species, so Malaria, Plasmodium ovale, and vivax, it's kind of based off of just those resistance patterns as well, and where the patient actually acquired the disease. So with the specific drugs, quinidine, this is indicated for Plasmodium falciparum. This is an IV infusion. So you typically do a bolus, 10 mg per kg over 60 to 120 minutes, followed by continuous infusion for greater than 24 hours. So this is an antiarrhythmic, so you do want to monitor your patient's cardiac status. Quinine is kind of similar to that. So they work in similar fashions to kill Plasmodium. When the Plasmodium infects the red blood cell and goes into that trophic or the feeding phase, they actually inhibit the metabolism of hemoglobin. So the Plasmodium can't get nutrients in that feeding phase. So with quinine, this is indicated for uncomplicated chloroquine-resistant Plasmodium vivax and falciparum infection. This is given PO for 3 to 7 days, along with doxy or clinda.
I love how it's 648 milligrams.
Yeah.
I'm 650.
Yeah,
that would kill me.
that
That
would
would
kill
too
me.
much.
So adverse effects here, you can see hypersensitivity reactions, hypoglycemia, thrombocytopenia. For the combination product, that Malaria combination of atovaquone and proguanil. So atovaquone works by inhibiting mitochondrial electron transport, and then proguanil is going to inhibit dihydrofolate reductase, so inhibiting metabolism. This is both in that erythrocytic phase of development. It's indicated for Plasmodium falciparum, including chloroquine resistant. So there's 2 different dosing schemes for prophylaxis and for treatments. Treatment is for 3 days, and then prophylaxis can be done 1 to 2 days before travel, stopping 7 days post-travel.
90% of what I write for malaria prevention is that.
Yeah. This is the only thing I've ever seen dispensed in retail pharmacy for malaria.
Oh, I do doxy a lot, but the Malaria, one of the things that's not listed up there that I would say is it can give people some wicked dreams. So something you have to tell them beforehand. Just, I mean, they'll be fine. It's not like that, you know, they'll see the uniform marrying the hippo kind of thing in dreams.
It's could be shanties.
Yeah, that's right.
Does everyone, you guys all do malaria prophylaxis, like anytime someone's going to an endemic area?
If we're going to an endemic area, absolutely.
I've just had multiple doctors, like when I'm going there, they're like, honestly, the prophylaxis is worse than if you got malaria, so I'm not gonna.
Not at all.
That is absolutely.
I've had 2 different ones.
Absolutely
I'm just curious
untrue.
if that's like.
In fact,
Malarium, yeah.
I'm waiting for you to
malarium's
finish,
bad.
but I don't know if you guys have ever seen. Have you guys ever seen a true like malaria flare, like a malaria hut or anything like that? It is awful. It'll make you immediately go home, get on a website, and go buy mosquito nets, like for whatever. Like if you see these kids with malaria, like true malaria. I mean, you had 38 of them at one time. I've seen it.
I'll tell my story in a minute.
Yeah, it is rough, and I disagree completely. Malaria will kill you. It can be bad. So if the CDC tells you they're going to an area where it's recommended, there should be no question in your mind. They should receive the prophylaxis, short of they make a decision that they don't want to because of whatever. You know.
So I think it's good. Let me tell my take on that because I dealt with a population that was smart. They looked things up. They got advice. They had friends. So 725 Rangers, Army Rangers. They're very fit and make you proud. But a friend of mine, Russ Cotwall, was their physician. And so they went to Afghanistan, fully carrying every prophylaxis. In this case, I think it was methadone that they were using to be protected in Afghanistan, which is considered a moderate risk area, primarily Plasmodium vivax. It does have some falciparum and it's quinine resistance. So they go in knowing that 100%, and they're going into some bad places. So they spend about 45 days there, they leave, and then 6 months later they go into Iraq. And then we get our first case of malaria. Then we get our second case, and then 36 more. So the thought was that they had contracted malaria in Iraq, which is a low to no risk area that you don't use any prophylaxis in. But as it turns out, they were going through all of the phases, secondary replication, third production phase, gamete, they had contracted all this in Afghanistan. We had some very, very sick people. All total, 38 out of 725 contracted. We've tried to figure out why.
Why did they take malaria?
Is the treat. Guess what? Guess what? These soldiers who do exactly what you tell them to do, what their percentage of compliance was. Less than 50%. You can read the article in JAMA if you'd like. But this really happened. And even knowing that you're going to an area that you're going to be exposed, these young folks only took it 50% of the time. But that's a pretty high instance rate. So 38 to 725. We almost lost one of the soldiers who got into our ARDS from the response. So, and now they're subject to a flare for the rest of their life. So I'm a big proponent in treating, just from my experience. Yeah, you can look that up. It's KOTWAL, and it's in jail.
If you guys ever are around, like, if I ever hear what that doctor did to you, Argo,
2. But it's Daniel.
if you ever say that a medicine is worse than a disease, and you have not seen that disease, I will fire you on the spot. Like, you do not, I guarantee you that those doctors have never seen malaria. And maybe on a movie, but not in real life. Because that is just they shouldn't have done that to you, put you at risk for something that you shouldn't have. Medicines all have side effects. You guys deal with this every single day. Every medicine has a side effect, and certainly you have a side effect with medication. But that's why the CDC is set up the way it is. These aren't dumb people looking over these guidelines that sit there and say, this is what you should take should you go into this area. I mean, they don't get anything out of it. All the CDC takes is crap, right? If they're ever wrong or something outrageous, they're the ones who take it on the chin. So I don't feel like they're overly cautious. I feel like they're appropriately cautious in the these things. And when you guys have someone traveling, do your due diligence to look at the CDC.gov website, and everything that's on there should be offered and encouraged. And if they decide not to take it, then they decide not to. Okay, as long as you're thinking about it. The CDC website that you're going to go over, right, is amazing, right? You can click if they're pregnant, you can click how old they are, go through it, and it'll, based off of those things, you don't have to think. It'll say, you're going to this city, this is what you do. Sorry.
No, it's just the fact that it happened twice. I was like, is this a thing? Like, are people not?
Well, I think it's, like, you made a passing comment about the side effects from these medications, particularly this one.
Yeah, malaria.
It's
crazy.
But having seen the after effects and knowing, you don't have to see it much to know that it's a bad dude. You don't want to deal with it. And the treatments, one of the treatments that we have that I particularly like, CJ mentioned in passing, is how serious is doxycycline? It's easy to take. Doxycycline's been around since before all of us.
Put on sunscreen,
Yeah,
take that bad boy.
say,
That's what I tell them. I'm like,
little kids.
don't give it to kids. Exactly. I don't give it to kids, and I slap on sunscreen.
The reason I use Mal run over that is because it's a week when they get back in out a month.
Not right. Not 20 days.
So I'm trying to increase compliance. But otherwise, that's a great drug. Yeah. But it was amazing to me, and not to brush this off, but how many times I'm talking to someone who's here for a physical or just, wait, what happened? What are you doing? Any plans for the summer? Oh, yeah, I'm going down. I'm going to Kenya with the. John, you get me shots? Have you had your. No, bro. What? Immunizations? Oh. It's amazing how many people will go to Costa Rica or go to these other places and not even think about talking to the doctor about it. So that's just something to remember when we're talking about patients.
Hey, and I'll tell you something that you'll get into. We have family friends that go to church with us. I'm going to give you the case that's presented because it comes at you in all different ways. It comes like you said, Ariel, and it also comes in my friends looking at me and said, oh yeah, I know exactly what you take. You take blah, 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 come by the clinic, you get it. All I know. We're going to pray about this. We'll be fine. Two faithful people. And I'm a faithful spiritual person. So know that you're going to have those conversations. And I think the best way to do that is to print out the information and give them a chance to go home and read it and make their own decision. But if you've explained the risk, you still treat that patient, even if they completely disagree with you. You know what I'm saying?
Pray about them taking doxycycline.
Yeah. But you give those alternatives
What are
because,
mosquito nets?
we know that it can sometimes, I know by first-hand account, it can take 200 plus days sometimes to show them already, but know that you'll get that in clinic. That's no different than somebody saying, I don't want to take immunizations to me. I'm like, all those people deserve care and the best medical advice that we can give them, but we don't keep them out of our clinic. That makes sense. You guys get what I'm saying?
So yeah, finishing up, malaria indicated for Plasmodium falciparum, including that chloroquine resistant. Different dosing schemes for prophylaxis versus treatment. There is black box warning for neuropsych effects, and then warnings for arrhythmia, QT prolongation, agranulocytosis, and hepatic impairment. Contraindicated with seizure history, so not a benign drug here. Chloroquine, again, we have our different prophylaxis treatment regimens. This does have renal adjustment for creatinine clearance less than 10. Several warnings here, so retinopathy, macular degeneration, arrhythmias, QT, myopathies, extrapyramidal reactions, agranulocytosis. Several side effects here as well. Things to monitor would be your CVCs for seizures, hepatic damage, and then auditory damage as well. You want to avoid this with a G6PD deficiency also, and this is safe for pregnancy.
Did you come across anything that says that someone's going for a mission trip for a week, they're going to have 6 doses of this? I mean, do you do CVCs, LFTs? for some of that, or is that more for long term? Did you come across that anywhere? I haven't written this in so long. I forgot.
I feel like that would be more for the long term. I didn't see any specific recommendations as to when exactly to monitor that, but
And most people we see are not for long.
yeah. And then primaquine, so this is indicated for Vivax, Oval, and falciparum. Again, want to screen for G6PD deficiency here. Contraindicated with other drugs that can cause hemolytic anemia, agranulocytosis, and acute illness. Some side effects here, so it can cause hemolytic anemia, arrhythmias, QT prolongation. So we start to see, some similar things with some of these drugs. They are structurally similar, and this one is not recommended in pregnancy.
Was that one the one that kills the hypno or whatever?
I've never written that medicine. I'm not sure. I've
Yeah,
heard
so
of that medicine.
potentially, because that's the Oval and the Vivax species that does the hypnozoite.
Yeah.
And then finally, we have doxycycline, so indicated for falciparum, prophylaxis and treatment dosing, contraindicated in pregnancy in children less than 8, and like we mentioned, the photosensitivity reactions. So, like we've said, throughout this lecture, CDC is really a great source of information. They have more information than you want on any of these disease states. They also do have a malaria hotline, which you can call, and emergency consultation for after hours as well. And that's it for my
Thank you.
And looking at your quinine question, and it seems like the FDA took away any unapproved quinine, so the life transfer, but you can still get it for the approved indication.
Okay.
Yeah, it looks